Good evening. If you're just joining us, thank you. We're going to wait a few minutes for our attendees to come in from the waiting room, and then we'll go ahead and get started. I think we'll go ahead and get started. Good evening, and thank you for joining us this evening for a discussion on advanced procedures and long-term pain relief. I am Jillian Benson, the Patient Education Specialist at National Spine and Pain Centers. Both Dr. Finkelstein and Dr. Johnson will be presenting this evening. Dr. Finkelstein earned his MD with honors from St. George's University School of Medicine. After an internship at Staten Island University Hospital in New York, Dr. Finkelstein completed his residency in anesthesiology at St. Joseph's Regional Medical Center, New Jersey. Dr. Finkelstein completed a pain medicine fellowship and was a chief fellow of pain medicine at Beth Israel Medical Center's Department of Pain Medicine and Palliative Care in New York, one of the most intensive interventional pain management fellowships in the country. Dr. Finkelstein currently serves as the Regional Medical Director for National Spine and Pain Centers. Dr. Finkelstein strives for an honest and forthright relationship with all of his patients. First and foremost, his goal is to create the best possible plan of care, maximizing all available therapies to ensure his patients' pain relief. He enjoys traveling with his family and friends and tries never to visit the same place twice. Dr. Finkelstein volunteers as a physician in the community and has served as a volunteer emergency medical technician. Dr. Johnson joined National Spine and Pain Centers in 2018, bringing with him Dr. Johnson joined New York Spine and Pain Centers in 2018, bringing with him more than 25 years of experience. Graduating with a Doctor of Osteopathic Medicine from the Missouri-based University of Health Sciences, he spent nearly a decade serving in the United States Air Force in different capacities, including as chief of the acute care clinic at Hanscom Air Force Base in Massachusetts, and as a clinical instructor at the Wilford Hall United States Air Force Medical Center, Department of Anesthesia at Lackland Air Force Base in Texas. Moving into the private sector in 1992, Dr. Johnson devoted his practice to the Kansas City area, rising from staff member to medical director at the Columbia Surgery Center of Kansas City and St. Joseph Medical Center, where he oversaw pain management. Dr. Johnson is board certified in anesthesiology, hospice, pain management, and palliative medicine. Before coming to New York Spine and Pain, he worked in the pain management centers of St. Joseph, St. Mary, and Menorah Medical Centers, and was president of St. Joseph Pain Associates. In his downtime, Dr. Johnson enjoys biking and running. His daughter is a marathon runner, and he often runs short 5K jogs with her before her competitions. Traveling and cooking together with his wife is also his passion. There will be a Q&A function throughout the presentation. You can simply type your questions into the box at the bottom of the screen. Please do not hesitate to ask throughout the webinar, as many of your questions will be able to be answered live and/or the answers be typed right back to you. Should you have any further questions after the webinar wraps, please don't hesitate to reach out to me directly. My contact information can be found on the last slide of the presentation. The email there is a direct link to me as well as my phone number. And without further ado, I will turn it over. Thank you again for joining us this evening.
Good evening, everyone. I'm Dr. Finkelstein. I'm going to get the lecture started with first a little bit of introduction about what chronic pain is. Next slide, please. So chronic pain is something that is long lasting. It's not spraining your ankle. It's not something that goes away with a few days of rest. It's generally something that lasts more than approximately 3 months. That fits the definition. It can be triggered by an injury. It could be triggered by age, disease, or something that is a repetitive injury, such as carpal tunnel. Stress, environmental factors can affect it. Reuse can affect it. And the problem with chronic pain is chronic pain does not go away without treatment. What happens is when you stop treating it with either anti-inflammatories or some type of treatment, the chronic pain returns. Next slide, please. So we have a lot of types of chronic pain, and I'm not going to cover all of them here, but we're going to cover things that are very commonly seen in our practice. So chronic back and leg pain, degenerative disc disease that happens with age or injury, arthritis of the spine that also can happen with age and injury. And we see this even in younger patients. Something that is called failed back surgery syndrome used to be called post-laminectomy syndrome. And that is pain that persists after someone has surgery, such as fusion of the spine. Disc herniations, what many people know as sciatica, or other that can occur in other places. Spinal stenosis, again, caused by arthritis, disc herniations, or atrophy of certain elements of the spine that can make it difficult for you to walk or have leg heaviness. And finally, in the spine, we're going to talk about compression fractures. Generally happens with older people, females more often than men, and are very painful fractures of the spine that make it difficult for patients to do anything. Similarly, things like that can happen in the joints. Everybody knows about an arthritic hip, an arthritic knee. You can have degeneration of the joints without arthritis. Or you can even have pain after getting a knee replacement or a hip replacement that was supposed to solve the problem in the first place. Next slide. Treatments. As you guys can see, there's a lot of treatments that are available. The top row are treatments that are generally tried by patients with their primary care physicians. They'll try you on some medications, usually anti-inflammatories or muscle relaxants. They'll try some physical therapy or some rehab type treatment. Psychological therapy can sometimes work in helping cope with pain. Alternative therapies such as acupuncture, chiropractic, massage, things of that sort are also sometimes useful when injuries especially are muscular in nature. When we go to the second row, this is where we're doing a little bit more. This is more what we would call minimally invasive or interventional pain management. Therapeutic injections of nerve blocks, such as epidurals or facet injections. Something called radiofrequency neuroablation, where we can give long-term relief of symptoms that may only get short relief with nerve blocks. Medical implants and devices, such as spinal cord stimulators and some of the other items we'll talk about. And finally, that green box is something that's dreaded by most patients. It's surgery. Our goal, using the interventions I mentioned, is to keep you away from that green box. Surgery, unfortunately, is never 100%. You have a great chance of improving, and with certain procedures, it's very high. But with a lot of procedures, especially those of the spine, the chances of improving are only 50-50. And nobody's quite the same after surgery. That's the issue. Next slide. So Dr. Johnson and I are going to cover a number of items here. You can see them yourself here. We're going to go through each of one of these items and discuss it in a little bit more detail. Next slide. And I'm going to start with spinal cord stimulation. Next slide. So spinal cord stimulation is an advanced technique. This is generally for patients that have either had failed back syndrome, meaning they failed surgery and have pain after they had a fusion or some other type of surgery of the spine, or for patients that have pain that just does not respond well to treatment or have short-term relief with treatment, injections that only last weeks or months and have to be repeated regularly. With a spinal cord stimulator, what we're doing is we're blocking the pain signals. It gets implanted in and around the spinal cord, and the device sends out a signal to block the pain signals from traveling from the painful area to the brain. It looks like a pacemaker. It's a very small device, very unintrusive, and it sends mild stimulation. In the old days, you used to feel that stimulation, but with now new advances, not only can you get MRIs with the devices, but you don't have to feel the stimulation, and yet it's very effective in blocking the pain signals. Next slide. So what are the benefits? The biggest benefit, what I tell patients, is this is the only surgery in the world that you can test drive. And what we do is we first figure out where the pain is coming from. Once we figure that out, we look at how it can help with your pain and with activity. The goal here is to improve your functionality. The implant is put in with a needle, just like an epidural injection, and an external generator is used so that you can see if this technology can help you. Okay. You'll have to have a psychological evaluation, regardless of whether or not you see a psychiatrist or a psychologist or a therapist. That's something that's required by Medicare and most of the insurance companies, just to make sure that you understand what the device can do for you. Next slide. So the trial is done in the office. We sometimes give you a little bit of sedation, usually by mouth, something like a Valium. It takes about 15 to 30 minutes to put in, and it's a small wire that is labeled 1 there, temporary trial leads, that goes in and basically just does the stimulation for you without having to have a real surgery. We keep the stimulator in for about 3 to 7 days, probably 5 days on average. And those 5 days, we can see whether or not you're going to get the relief that we're hoping for. Next slide. Now, let's say after the 5 or 7 days, you say you have great relief. Things that we hear are patients can do more things. They can spend time with grandkids or children. They can walk better. They can sleep better. Those are all things that are possible with the stimulator. If we decide that you get at least 50% relief or 50% improvement in functionality, we then proceed with a permanent implant. Permanent implant is a small surgery. It's an outpatient procedure. You're in the hospital for just a couple of hours. The surgery itself takes about an hour or so. It's done with sedation. So anesthesia is there just to make sure that you're comfortable. And the recovery period is very minimal, meaning we're really only waiting for the incisions to heal. And you wind up with 2 small incisions, one about 1.5 inches, one about 2 inches, just to put the device in place so that it's secure. Next slide. The next thing I'm going to talk about something which unfortunately affects a lot of our older patients and is very, very painful. It's called kyphoplasty. Spinal fractures occur in patients as they get older or they get osteoporotic. They can also occur in patients that have injuries, car accidents, falls, things of that sort. A spinal fracture is just like a fracture of a bone. You break your arm, we can put a cast on it. Unfortunately, with a fracture of the spine, you can't quite do that. Next slide. So the bones of the spine are stacked one upon each other, and they're done in a very specific shape. As they get older, patients have osteoporosis, which basically means thinning of the bone. It can happen also in patients that have to take steroids long term and a couple of other conditions. You can get fractures in multiple places, and sometimes they're very mild. And in the picture on the right, you can see patients have that sort of lopsided look, that humpback. That's very common. Those are small fractures that between all the vertebrae of the spine that can give you that position. Those may not be painful. The ones that occur acutely from a fall, an injury, or just from bending over are very painful and are very limiting. Next slide. The fractures are called vertebral compression fractures, also called wedge fractures. The reason we call them that, because if you look on the right side, the vertebrae, the front of the vertebrae normally looks like a box. It compresses to look like a wedge. That tends to do 2 things. It causes you to bend over because your spine is bending. It prevents you from doing things because as the bone moves, it's very, very painful. The issues that you have further is it causes some instability of the spine. The fracture puts more pressure on other joints, puts pressure possibly on the nerves that go down, causing symptoms such as sciatica, and can cause fractures to occur in other locations as well. Next slide. Again, we went through this, but very common things: sneezing, bending over, planting. These are things that have all caused fractures in patients. Next slide. So what are the old treatment options? So in the past, we would put somebody in what was called a turtle brace, which was basically a large brace, front and back, that prevented your movement. That was our attempt to cast the patient, prevent the movement, hoping things would improve, hoping that the patient would not move and it would heal. Unfortunately, not very effective. We tried to add pain medication. Again, not very effective because every movement hurt. We tried to put people in bed for weeks, which made them even worse. So we had to find something better. Next slide. Kyphoplasty was invented. It's a second stage of a procedure that was called vertebroplasty. but it's basically a minimally invasive procedure done in the office where we use a device to actually push away some of the bad bone, possibly even raising and restoring some height in the broken bone. We then fill it with a special type of biological cement, which internally casts the device. Takes anywhere from 15 to 30 minutes. And the most amazing thing is patients lay down on the table with pain and very, very often will get up after the procedure with a significant decrease in pain, which even gets better over the next several days. Next slide. So what's the goal of the procedure? Really, three things. Restore the height, stabilize the fracture, and stabilizing the fracture is what eliminates the pain. And we want people to get back to activity. The goal is you do this as quickly as possible so that the patient does not get other issues from spending time not doing things, spending time in bed, not doing activities. So we want to get you back to activity as quickly as possible. Next slide. I'm going to just go over the benefits quickly. Less narcotics use. Really, this can be done the day after you have a compression fracture. No narcotics use is necessary. You don't have to go to a nursing home because of the bed, being in bed or having a brace on. And satisfaction rates are very, very large as compared to medications or bracing. Next slide. The next step, and this was something that was invented about 15 years ago and has been around in Europe for about just as long, is the next level of kyphoplasty. So previously, kyphoplasty was done with a balloon, and very often that is still the optimal solution for most patients. For patients with certain conditions, such as bony impingement into the spinal canal or fractures that are very, very fresh, we have a new thing called spine jack. And spine jack is just what it sounds. It jacks up the vertebrae internally, and you can see the picture from the top left shows the top wall of the vertebrae is compressed. This is a little device that gets implanted and can actually push up that back wall. It is then filled with cement, just like the standard kyphoplasty. And we've seen great results with this. And this is now the most advanced technique available for compression fractures. Again, this can be done in the office, and you have the same type of relief or better than you do with standard kyphoplasty. Additionally, the restoration of height with spine jack is better because it's a mechanical device that actually locks the walls of the vertebrae in place. Next slide. The next thing I'm going to cover is something that happens to everyone. Some patients have symptoms, some patients do not. But this is something you see very, very often. It's called lumbar stenosis. This occurs with everyone as they get older. The degree of stenosis is what's going to determine if you have symptoms or not. Next slide. What happens with spinal stenosis is either the bony segments of the spine or the ligaments that hold the spine together put pressure on the spinal cord. You can get numbness, tingling, weakness of the legs, heaviness of the legs. And that's the problem. It affects everything basically from your waist down. It makes it difficult to do activities, difficult to walk, can give you pain in the legs that we call claudication. And this is something that is now treatable with a variety of number of things that we'll mention. Next slide. So what are the indications? And before I go over the indications, I'm going to turn your attention to the right side. There's a very classic view that we see, and actually it's actually called a shopping cart sign. You see it often every time you go to the supermarket. It's the little old lady that's leaning on the shopping cart. And she's not doing that because she's weak. She's not doing that because she's tired. She's doing that because that forward bending makes it easier for her to walk. Bending forward, what it actually does is it relieves some of the stenosis in the spinal cord to allow the patient to walk further. So the indications are having stenosis on imaging. So we do an MRI, make sure you have stenosis and it's not some other type of pathology. Difficulty in walking straight, meaning upright without bending over. Difficulty walking long distances. These are patients that often have to stop and rest because they get tiredness in the legs, heaviness of the legs. A couple of minutes of rest, and they can keep going further. And the typical person that I showed you there with the shopping cart side needs to lean on a shopping cart to be able to get around a trip in the supermarket. Next slide. So I'm going to talk about the two most advanced procedures that are available. I'm going to discuss the first one, and Dr. Johnson will take over and mention the second procedure. So Vertiflex. This is about 8 or 9 years old. And basically what we looked at is how can we give patients relief of spinal stenosis similar to what they get when they bend forward, but allow them to do it without having to bend forward. The Vertiflex procedure is a small surgery, minimally invasive. It's not even considered a spinal surgery. It's considered minimally invasive decompression, where what we put in, if you look at the right picture, you'll see a little purple device that sits in the back of the spine. What it actually does is it mechanically causes your spine to open up a little bit. It relieves pressure on the nerves, releases pressure on the spine. And we do this generally in the lumbar spine or the low back, where most of the symptoms come from. It's a tiny incision, about 1.5 centimeters. It's a same-day procedure. Again, you go to the hospital or surgery center. It's done in an hour or so. We do not remove any bone or any tissue. So this is what really differentiates it from a spinal surgery. We're not taking out bone and causing permanent changes in the spine. Recovery is a couple of days. Risks and complications are very low, much lower than with spinal surgery, and it can be put in permanently. So it stays there and it gives you relief over a long term. As of 2016, it mentions that 10,000 patients have done. That number right now is close to 30,000. So this is something that's very effective, and patients come back to it often, because if you have spinal stenosis at more than one level, it can be done at multiple levels as necessary. Okay. So next, we're going to go to the next slide, and I'm going to turn the conference over to Dr. Johnson. He's going to talk about mild and then a couple of other procedures that we have.
So as Dr. Finkelstein was saying, spinal stenosis causes a host of symptoms, back and leg pain. And stenosis just means a narrowing. The back is getting pinched. One of the things that oftentimes will pinch the back is a ligament called the ligamentum flavum. The mild procedure is a percutaneous procedure, meaning it's really not a surgical procedure. It doesn't chip away bone. It's done through a needle, again, with just a little minor sedation. And its goal is to lessen that ligamentum flavum, to take some of the compression out of the back. The procedure takes 30 to 40 minutes. It's, like I said, done as an outpatient. When you leave the procedure, your back has been decompressed. There is now a great deal more space in the lumbar area. And those symptoms of neurogenic claudication, meaning that the spine just isn't getting good blood flow, it's getting pinched, back pain, leg pain is greatly lessened. Again, a minimally invasive procedure, not really a surgical procedure in that it doesn't nip away bones, it's done through a needle. Next slide. The next procedure we're going to talk about is percutaneous discectomy. Next slide. So there are a couple of things that can cause narrowing of the spine or stenosis. Again, we talked about sort of bony areas where the back gets pinched, and you can use the Vertiflex, ligamentum flavum hypertrophy, or just excess growth that we can sort of nip away through the mild procedure. Sometimes discs will bulge backwards and compress the spine a little bit as well. Percutaneous discography has been around for quite some time. There are a variety of ways to do this. Again, it is a non-surgical percutaneous procedure. We keep using that word percutaneous. It means it's just done through needles. You can place the needle into the disc. There are a couple of things we can do. One way to take the swelling out of the disc is to simply remove some of that tissue. That is, by definition, percutaneous discectomy. Prior to doing that, we will want to do discography to determine if indeed the disc itself is causing pain. Percutaneous discography is, again, access through a needle into the disc. testing can reproduce some of your back pain, it tells us that we need to move forward with the decompression of that disc. Next slide. So again, we initially start with discography, meaning place a needle into the disc to see if the disc itself is causing pain. Minimally invasive procedure, done in the office, no recovery is needed. You can return to work the next day. If this shows that the disc itself is causing pain, we can move forward with the discectomy. Again, minimally invasive procedure. We do it with a little IV sedation. It's outpatient, home that same day. Can return to work within a few days as long as it doesn't require a lot of heavy lifting. Next slide. Radiofrequency ablation and neurotomy. Next slide. Ablation or neurotomy simply means that we're doing something to block the nerve. Typically, we create a very small thermal injury or a burn. We do this through radiofrequency. It can be done in the spine at multiple levels. Typically, it will give relief for up to 6 months, can be up to 12 months. It is done after diagnostic injections are performed to identify specifically what areas, and with radiofrequency in the back, we're looking at facet joints, the joints that allow for movement disc to disc. If those discs are causing pain, and we can diagnose it with injections in the office, we can come back and burn the nerves that carry those signals into the spine and ultimately up to the brain. Procedure is very quick, takes 5 to 7 minutes. The lesion takes up to 4 weeks to completely mature. And like I said, you'll get relief for a good period of time, typically 6 to 12 months. It can be repeated every 6 months or however often, up to a year typically, if needed. Next slide. So we've talked about a lot of back pain. Obviously, there are a lot of other pain generators that we sort of come across as you have a few birthdays. A lot of folks end up with some arthritis in the knees that cause significant pain. When the knee starts to cause pain, there are a number of things that we do. Oftentimes, we'll start by injecting some steroid into the knee. Sometimes, if that doesn't give good relief, we can do a gel injection where we inject a supplement that sort of glues onto the cartilage and builds up the cartilage again and enables folks to get around for a good period of time. If, however, we're unable to treat the pain generator, we know the knee is still causing pain and we can't seem to make that joint quiet down, we can simply block the signals coming from the knee. There are 3 specific genicular nerves that carry pain signals from the knee up to the spine, up to the brain. Fortunately, these nerves have no other sensory function and they have no motor function. So if we burn them, we don't cause any weakness and we don't cause any areas of numbness. It's an elegant way to treat pain from the knee. We first start by doing an injection of local anesthetic at the 3 spots you'll notice on the left-hand side, the superior medial, superior lateral, and inferior medial genicular nerve. That diagnostic block gives you short-term relief that is predictive that we can come back and burn the nerve and knock it out for a much longer time. Next slide. Again, sort of jumbling these a little bit, but going back to the spine. We talk about sort of arthritic changes that occur in the spine. Typically, folks shrink about 2 inches by the time they reach 70. All those discs you see on the bottom tend to flatten out. When that occurs, the facet joints start to become a little bit arthritic. And just like the genicular nerve, there's a facet nerve that has no other sensory functions and no motor functions. So if we can't quiet the facet joint down by injecting into the joint, we can do a diagnostic block, putting a drop of local anesthetic near that nerve. And if that predictively gives you relief for a number of hours, as long as the local anesthetic lasts, that is predictive that we can come back and burn those nerves. And again, get relief for a period of time, anywhere from 6 to 12 to 15 months. Again, we'd have to do the diagnostic block first, of course. And it can be done in the cervical spine, the thoracic spine, or the lumbar spine. Next slide. Back to you, John.
Okay, so the intercept procedure is something that's I'm going to say relatively new. Um, to the degree that some insurance companies don't even allow it yet. Fortunately, it is allowed by Medicare and it is allowed by a lot of the New York insurance companies. And it's something that is very, very advanced in the sense of our understanding of pain and where it comes from. So we've spoken a lot about different things here. We've spoken about discs and joints, but just as similarly, and Dr. Johnson sort of touched on this before, as patients, as he put it, have a few extra birthdays, you get arthritis of the vertebral bodies itself, the parts of the spine that are the building blocks. Okay, next slide. So the Intercept procedure is used for people that sort of fail other therapies. So when you rule out the disc, when you rule out the joint, um, anti-inflammatories don't work, injections don't last too long, and you don't want to have spine surgery. Because unfortunately, spine surgery has been around for a very, very long time. And I'll let you know, there's never been a very, very effective way to treat arthritis. Their way to treat arthritis with spine surgery is to immobilize the spine. If the joints, arthritic joints, don't move, you'll have a little bit less pain. Unfortunately, there's no surgery to fix the vertebral bodies themselves. Next slide. So what's the Intercept procedure? The Intercept procedure touches on something Dr. Johnson spoke about, radio frequency ablation. Over the last several years, what we realized is a lot of the bony pain that comes from the vertebrae itself comes from a nerve. That nerve, unfortunately, is not on the outside of the bone, but is on the inside of the bone, and it lies on the inside of each vertebral body. And that's also one of the nerves that causes pain that occurs when you have a compression fracture. So there's a nerve called the basovertebral nerve that runs on the inside. This procedure is done very similar to kyphoplasty without use of cement. What we do is we use a needle, we go into the inside of the vertebral body, and we use a special radiofrequency probe that deadens that nerve. Again, this is a nerve that has no function except to feel pain. It doesn't innervate any muscles. There's no sensation from it. It just feels pain. So when we deaden that nerve, you can get relief for up to a year of pain being caused by bone. It's a minimally invasive procedure, can be done sometimes in the office or at a surgery center. It's a little bit uncomfortable, so some sedation helps. And really, you can return to work in a few days. Again, if lifting's not required, we just want the healing to take place. And that's with most of the procedures. Next slide. Okay, so this is Jill's information. I'm going to touch on a question that patient mentioned there. So why do more procedures tend to target the lower back and not cervical problems? That's a great question. A lot of the procedures that we discussed, radiofrequency ablation, a lot of the injections can be done in the cervical spine as well. The cervical spine, with a lot of the more advanced procedures that we covered, doesn't have the same problems as the lumbar spine or the low back because it carries a lot less weight. So a lot of things like compression fractures and arthritic changes occur more frequently in the low back just because there's more weight and more wear and tear on those joints. We do apply a lot of these same procedures to the neck, and you can get arthritis. Generally, arthritis in the neck may not cause as much pain as the low back because the head is later than the rest of the body, and there's less movement there. But movement can be restricted, and we can do a lot of the procedures. You generally don't have compression fractures in the cervical spine, and a lot of these things don't occur in the neck, but they can be done in the mid-back, which is very common for thoracic fractures. And the Intercept procedure as well can be done in the lower thoracic spine if necessary. Spinal cord stimulation, we didn't mention it, but spinal cord stimulation is very effective for treating pain in the neck and the upper extremities.
Another patient asked specifically about back and leg pain. that has failed sort of the initial conservative therapies that we do, assuming that there is not a surgical option, back and leg pain, not amenable to other therapies, is often very well addressed with a spinal cord stimulator. And that would be likely the next logical step to trial a stimulator. Again, a non-interventional procedure, and you can take it for a test drive. Like Dr. Finkelstein said, that's the only sort of back intervention you can do that you can undo. Put the device in. If it works for you, great. We can go ahead and implant it. If it doesn't work for you, then we do need to kind of re-evaluate and see, what are the pain generators that we might be missing. But the stimulator is an excellent option for folks who have failed other conservative therapies.
One patient asked, would a spinal cord stimulator work for someone who's 89 years old? I can tell you personally, and I think Dr. Johnson can as well, I have implanted spinal cord stimulators in patients over 90 years old. Age for this does not matter. So they also questioned hip pain. Hip pain, it depends. It depends what exactly is causing the pain in the area of the hip. Very often back pain, or what we call axial back pain from the facets, can generate pain that's referred into the hips. So again, because it is something that you can trial, we can often try it, and a lot of times we can get relief of pain in the area of the hip with a spinal cord stimulator. Age is really not a big issue there. Comorbidities is not an issue. So you can do this in patients that have heart disease, asthma, diabetes. It's effective in all those patients because it doesn't interact with any of those issues and doesn't carry the risks of major spine surgery.
Another patient had mentioned that they've had a couple of microdiscectomies and still have a disc fragment causing pain. And their question is pretty straightforward. Is a stimulator a better option than fusion? Here is the deal. If you're having weakness in a leg, then that's probably a surgical option. If it's pain, again, spinal cord stimulator is a much less interventional procedure. A fusion has a pretty long post-recovery period. And once you've had a fusion, it's there. You're going to have a little bit of increased movement above and below the fused area. So if you can, our goal is always to do the least interventional thing to get you more functional.
The current recommendations, I'm going to take a step back. Recommendations 20 years ago, when spinal cord stimulators first came out, was if you have symptoms such as that, you have pain down the leg, do a fusion. Unfortunately, thousands and tens of thousands of patients had fusions and had either, like yourself, either the same pain or more pain. As spinal cord stimulator technology has advanced, and it's advanced dramatically in the past 5 to 10 years, that thinking has changed. Spinal cord stimulators are now considered a first line of treatment before surgery. So like Dr. Johnson said, if you have weakness, bowel issues, urinary issues where you can't control your bowels or urinary bladder, that's surgical, obviously. But pain, numbness, tingling, that can often be cured, or let me correct myself, treated with a spinal cord stimulator, not requiring surgery. The great thing about it is a spinal cord stimulator does not prevent you from later having surgery. Okay. It can be taken out. Oftentimes they'll do surgery and ask us to put it back in because there are a lot of symptoms that surgery just cannot fix. Do we have any other questions? We have a few. Okay, okay. So question is, we just have to scroll down. In addition to 2 herniated discs, spinal stenosis, I'm dealing with immobilization due to the arms to the arthritis. Is there any help for a patient who is 86 years old? Okay, so a couple of things. Injections. Patients often ask me 2 questions. First question is, how many injections will I need? And the second question is, how long will it last? And I will tell everybody in the audience now, Dr. Johnson and I have been doing this for a long time, and we have no idea. Okay. You can have patients that have a great amount of pathology, and with one magical injection, they're cured. We don't do anything special for the injection, but everybody responds differently to the medications, and everybody's pathology is different. Some people require 2-3 injections to get them pain relief, and they're good for 6 months. Some patients need 1 injection every 3 months. Recently, I saw patients that I did injections for 3 years ago. The pain came back, so they came back for more injections. They've had nothing for 3 years. They've had relief. So it really is different based on each patient, and it's not something we can really predict. Now, you mentioned your shoulder as well. We'll treat both pathologies separately. So the neck and the shoulder are very different beasts. We'll treat each of the items separately to get you relief in that joint. And it depends. The level of arthritis, you may have some loss of function, but very often pain is what limits your function. And if we can get rid of the pain, you may have more range of motion. I hope that answers your question. Next question. Next question, Dr. Johnson. Let me just take this one because I happen to know this patient. Okay. So it's a patient with multi-level fusion in the neck, loss of height, and it's a patient is having what's called occipital neuralgia. Occipital neuralgia is a nerve that comes out of the base of your skull and wraps around your skull, and it causes pain on one side of your head. Often people have pain in the scalp, up in the eye, in the brow, and it's very painful or very distracting. It feels like a headache, but a one-sided headache. Spinal cord stimulation, I have done spinal cord stimulation for occipital neuralgia. It is an off-label use, and it works sometimes. It is a high-risk procedure, not covered by most insurances. So that's something that we have to discuss, but it's often not done anymore.
So next question is, what is your opinion of chiropractic manipulation of the spine or acupuncture for back problems? Again, there is no one panacea to treat everything. Acupuncture has a 5,000-year history. It can be effective as another tool to help treat pain. Chiropractic manipulation can be helpful for some acute things. Obviously need to be careful, especially as folks get a little osteoporotic. I'm a doctor of osteopathic medicine. I was trained to do some manipulation. There are some instances where that is useful. For chronic pain, the results are not usually great. They can be helpful. I think the downside of trying it is pretty small. And I think there was another question coming up down there.
And from patient DS, spinal cord stimulator implanted 10 years ago. Okay, I'm going to just stop reading the question right there. Spinal cord stimulator implanted 10 years ago should be replaced. As I mentioned, there have been so many advances in the type of treatment that a spinal cord stimulator can replace that very often just changing the generator, leaving the wires in place, if they're properly placed, we can make a small incision and basically in about 10 to 15 minutes replace the generator and give you a whole slew of new treatment options. So absolutely, again, we would need to examine you, we would need to evaluate you, we would need to see where your wires are. But yes, a stimulator that's 10 years old and is just not functioning and still implanted can be made more advanced to treat more options.
The technology has advanced dramatically. And regarding spinal cord stimulators, for osteoporotic fractures, well, actually osteoporotic fractures have very specific treatment algorithms. Again, if it's a compression fracture, which is by definition what it would be, they are best treated by correcting the fracture, by doing a kyphoplasty or a vertebroplasty.
Question for the patient that has the diffusion. Are there any other treatments for cervical pain Basically, if it's occipital neuralgia, so we can do radiofrequency ablation of the occipital nerves. The one issue that patients need to understand with that, we can discuss it in more detail with the physician, is that that is a nerve that does carry sensation. So radiofrequency ablation of that nerve may help with the pain, but at the same time, it would cause numbness on half of your scalp. With a lot of the radiofrequency procedures that we do, you can often get a small area of numbness over the kneecap with genicular nerve RF, a small spot in the small of the back with lumbar RF. This one, the area of numbness is quite a bit larger and is distracting to a lot of patients. So it has to be, we have to discuss really the risks, the benefits, and the downsides of doing such a procedure. But oftentimes it is done as long as the patient has understanding that this numbness can last for up to a year, as long as the pain relief does.
And can you do kyphoplasty on healed fractures? Typically not. We do kyphoplasty on fractures that are still mobile. In other words, they're still moving. Typically when a bone breaks, what hurts is the movement of the broken bone. If you ever broken your arm, it hurts like the dickens. As soon as it's healed and take the cast off, it's fine. Similarly, once the vertebral body has healed, the pain should improve. However, if you are osteoporotic and had a compression fracture and it healed, you still are at a very high risk for having subsequent fractures. So if you're still having ongoing pain 8, 10, 12 weeks after an initial osteoporotic compression fracture, it's highly likely that you have another fracture, and that can be addressed with kyphoplasty.
We do special imaging. So what a lot of people consider chronic, we've seen fractures, as Dr. Johnson mentioned, happen again and again in the same vertebral body. And they may be very small fractures, something we call microfractures, just because the bone is so weak. And we can do imaging to see that. I have had many patients that have had fractures that are many months old, but continue to have pain. And with those, if they're totally healed, the intercept procedure may be something that may be beneficial. And putting a little cement in there often serves a very similar function to stabilize the microfractures and gets rid of a lot of that pain. Somebody mentioned that they're going to see Dr. Johnson tomorrow, so you could discuss that with him when you see him. A patient asked a question about RFA. So the question is RFA more effective than cryoablation for occipital pain? RFA and cryoablation are the same thing, basically. The difference is in radiofrequency ablation, you're using heat to create the lesion. In cryoablation, you're using cold. Believe it or not, cryoablation is still considered by most insurance companies an experimental procedure, but the outcomes are basically the same. Radiofrequency ablation or thermal ablation can be done on anything that cryoablation can be done on, is covered by insurance, and is just as effective. Patient asks a question. Would you get a neurostimulator implant before SI joint fusion? Pain in the lower back, groin, and hips. Absolutely. So the way we consider the SI joint, it's called the sacroiliac joint. The best way to describe it is it's the lowest facet joint. It's really the joint, it's a very large joint at the base of your spine that connects your spine to your pelvis. That spine suffers the same exact issues that you suffer in the lower spine. So rather than having an SI joint fusion, you can absolutely try a stimulator to see if it'll control the pain, because it is spinal pain. If it doesn't, again, the stimulator can come out very quickly. And other procedures need to be done to confirm that the SI joint is actually your area of pain. And we can do diagnostic injections there to confirm whether it's coming from the lower levels of the spine or from the sacroiliac joint. So really, it would have to be based a little bit on examination, some imaging. SI joint fusion is something that's new. A couple of years old. It's changed quite a bit. The first system did not work well. There's a new system out there. It's generally done by the orthopedic surgeons. And there's not a huge amount of indication for it. It's not done frequently because there are things that can be done that are less invasive and work much better for that type of pain.
Another patient asks about, again, neck pain, which is arthritis. And again, it's hard to answer patient-specific questions. We would need to kind of take a look, do a physical exam and look at the diagnostic studies. But in general, arthritic changes tend to be facet joint pain. And as we spoke, direct facet joint injections, medial branch dorsal rami diagnostic blocks, that's the fancy name for the nerve that carries the pain signal from the facet joint, can be done. And if that helps, then we can ablate that nerve with radiofrequency.
Let's see if we have any other questions. Okay, I think we've answered all the questions that we have there. Does anyone else have any other questions that you'd like to have answered? Okay. Microdiscectomy. Will microdiscectomy help my leg pain from a disc bulge? Possible. Okay. Microdiscectomy is a surgery. It's important to know that prior to doing a microdiscectomy, the first thing that needs to be done is we need to confirm where the pain is coming from and seeing if the nerve impingement is what's causing the symptoms. That's done with something called a diagnostic nerve root block. Okay. Very often, more often than not, that same injection treats the pain and gets rid of that pain. If you get very temporary relief, just as long as anesthetic, with a couple of injections, and like I mentioned earlier, sometimes you need a couple of injections. If the pain is only temporary, you sometimes need to have a microdiscectomy. A microdiscectomy is a little bit more than that because they do have to take some bone out to get to that disc very often. And that's what often causes pain in patients after surgery. So they do what's called a hemilaminectomy, where the name post-laminectomy pain syndrome came from. It's taking that bone out that causes the pain. So again, if we can avoid surgical intervention, that's our goal. And okay, question a patient asked earlier before the conference. For facet injections at the C1-2 level. The C1-2 level is very different. It is not a normal joint. It is what we call a pivot joint. The C2 vertebrae basically looks like your finger. The C1 vertebrae sits on top of it and your skull sits on top of it and it rotates. That's what allows you to rotate your head. The joints there are very different. They're not regular facet joints. And what makes it more complicated is the fact that the blood vessel that feeds your brain wraps around that joint. So for safety reasons and for the anatomy of the joint, facet injections are not done there because they haven't been found to be much use and they're extremely high risk. Somebody, patient MI says, didn't work. Should I try before having surgery? I think the question is probably regarding the spinal cord stimulator. Absolutely. Like we mentioned earlier, there's no downside to trying the stimulator. If it works, it's usually a home run. If it doesn't work, you've lost nothing. It's a couple of days. The risks are very minimal and the benefits are potentially very large. That's why it's such a great surgery for no matter what causes your pain. And that's the important thing with spinal cord stimulation, just like with radiofrequency ablation of the knee. We really don't care what the pathology is that's causing your symptoms because we're just going to be blocking those pain signals from going to your brain. That way, whether or not it's from arthritis or from discs or from any other issues, we can block those pain signals to give you less pain and give you more functionality. So absolutely, you should try it.
And again, it is a trial. We try and select our patients very carefully. However, sometimes we do a trial and the patients simply don't get good response. And that's an answer in itself. If the stimulator does not work for you, then we need to look at other options, and surgery might be one.
So I think we're nearing the top of the hour and it looks like our questions have slowed down. We might have one more left. And this one applies to everybody. Could I get a copy of this presentation? I cannot send the presentation, but it has been recorded and I will process it first thing tomorrow morning. So if you email me, I'd be more than happy to send you the link to the presentation and you're welcome to review it at your own speed and take some more notes if you wish. And if there's procedures that we discussed this evening that you would like more information about, please don't hesitate to email me there as well. I can direct you to our condition and treatment pages and help you get all the information you need that you can print if you wish. And again, if you have further questions that are lingering after the presentation has completed, don't hesitate to email me those as well. I can direct you to the right person to get answers for you. I just want to say thank you to Dr. Johnson and thank you to Dr. Finkelstein for being with us this evening, for taking the time to present on these advanced procedures and to answer these questions. Again, thank you for your time. I know everyone has a busy schedule these days, and I appreciate you all being here this evening. Again, if you have any questions, don't hesitate to reach out to me. And thank you and have a wonderful evening.
Have a great evening, everyone.